2 weeks to kind of equal out. So some of this includes prior auths, so we elected to not really address those at this RIE. So our goal is strictly 2 things: reduce your messages so you don't have 1,000 messages plus a week, and to get more timely completion of the messages. So everything we're looking at is that. And with that goal, we had to come up with some numbers, so we wanted to take that 86 hours and try and get it down to 48 hours to completion. So our average goal is 48 hours to completion. And then we have another little semi-watch goal, which is to complete 80% of all messages within 48 hours. So this is just to get them complete and out of there. They seem similar, but one is a percent that we can sign off and be done with. Another is just kind of averaging all this whole mess of time. So our challenge to do that, particularly the part that I was looking at, is that after the 13 hours and getting the message out there, providers take too long to get a response back. So that's the challenge that I saw for this group. And so we're going to try and come up with some experiments to see how we can facilitate standard work to help providers get this response back more promptly and more completely. So when we do that, some of the things are straightforward, like refills, signing off labs. Some of those things, there's nothing that we can facilitate. They just have to do it when they do it. But we looked at messaging and saying there are triage messaging that sometimes can be a little bit more complex. And when, as a provider in a different field, if I get a message that is 2 sentences, straightforward, I can say, oh, yeah, we need this or do this. And then there's those that are just kind of, this is problem patient or patient who's not even a problem patient, but all of a sudden is having all kinds of problems. It takes me opening the chart, reviewing it, thinking about it, looking at previous labs, looking at my previous notes. It takes a long time. If I'm trying to do them promptly as the day goes on, what I do is I go, oh, I've got 2 minutes between the next patient. I can answer this one. I can answer this one. Oops, this one's real complex. I'll just skip it and go back to the 3rd one after that. And then maybe at the end of the day I come to it, or maybe I say this is one that's so complex that I'm going to wait till I'm fresh in the morning, and then I forget fresh in the morning, and it's already 2 days. So we want to try and say, is there any way we can eliminate that? And when we look at these more complex messages, I looked at them as either being complex but straightforward. It's a patient has diarrhea, new diarrhea episode, fever episode. It's a straightforward thing, or it's complex because you're not exactly sure, it's not something we've dealt with this person before, they're a unique type of problem. So for the standard ones, even though they may not be complex, we thought about addressing it in a form of saying, we don't want re-messaging back and forth. We want, when the provider gets this, to have all the details we know that they're going to need, or at least 80% of the time most people think this is all we need. And that's where it's beyond my scope, but we asked Rob to look at and help come up with some templates to make sure that as you're doing it, we know that the doc's going to want all these things, you know it, but let's put it on a form so we don't forget and only give them 5 of the 6 things they always ask. And so Rob can talk about that. But I want to talk about the unique problems, the ones where you can't template it because it's something different. I call a unique problem something where there is a concern, there is a request that we all know that the patient or we have once we deal with this, and then there's all the detail, the story to get to that point. So when I look at a unique problem, there's all this detail that you guys do. You review charts, you talk to the patient, you look at previous notes in lab, you get all this detail. And sometimes that can be paragraphs worth. If I open it up and see those paragraphs, it's like, oh, this is too long, I'm gonna go to the next one. But you have honed it down already, and you know these are the main concerns this patient has. This patient has this concern because the pain's unrelenting, because they now have some other medical problem, cardiac disease, something like that, and it's affecting this. You know there's some concerns that the patient wants addressed. And you often might have some ideas about what that next step might be. So what we're going to ask, our ask for you, is to say, let's take this format that you're already doing and put at the top a brief summary of the main concerns after you kind of assess this problem. Like 1, 2, 3. These are the main patient concerns. Okay? It's not like just chief complaint, that's too simple, but it's not all the detail that's too long. Secondly, go ahead and make a request or make a suggestion if you have one. Should we order CT with contrast abdomen pelvis? should I have, whatever your suggestion, if you have one, you have permission to suggest stuff, because as a provider, that's helpful, because we know you're on our team, and we want you to suggest, because you've had all this time thinking about this. And then ask them, next steps, not a whole treatment plan, but what are the next steps, doc? And have that under the second bar. And then under the third bar, all that detail that you've been writing and accumulating, you may just have to copy and paste, put underneath there, so that when we open the chart, you've already done all our homework, thank you very much. And we don't have as much going back to do. So that's the format for the unique problem. And we'll come up with some change of standard work forms that you may want to talk about. But Rob, did you want to talk about some of the templates at all, and just hear our stuff?
So John Holden and I yesterday put together, came up with a few common symptoms that patients may be calling in about. So for liver patients, abdominal distension, lower extremity swelling, confusion, altered mental status. I think IBD patients also have their own set of questions, and then kind of general GI and motility, so nausea and vomiting, diarrhea, constipation, difficulty swallowing, kind of what things that John and I look for if I was on the phone with the patient, things that I would be inquiring about. And these are very similar questions that we also ask in clinic as well. Some of you are probably already doing some of this, but just to give you a template in case one day you're asked to cover motility and you're always doing IBD and or liver, what do I do? What do I ask? So it's kind of a framework of asking questions here. So obviously this is kind of a work in progress, but we just started this yesterday. We hope that this will continue to grow. This will become kind of standard questions, standard work, not only for us, but maybe extending this into other locations that we go to. We might not have as extensive and excellent nursing support like we have here. So our Tipton location, Lebanon, so everyone's kind of on the same page for all of us as providers for our patients.
So they actually, especially Dr. Holden, experimented with Janice, and Janice can kind of speak on the template. So in the standard work, what it kind of looks like is these are truly just symptom calls. This is not I want to resolve. This is not a I want to refill. This is truly that you're calling the patient, finding out why they're having a nausea, vomiting, abdominal pain. So basically, what's their concerns? 1, 2, 3. The next steps is going to be the area of, do you want me to order calprotectin and a C. diff? Or if you don't know based on whatever the patient told you, then basically on their next step should please make recommendations or please advise. And then down below will be all your your details of patient called, stating this, So it was really nice because the providers in the room all said the same thing. They opened up that message and I think Dr. Holden went this. Okay, so we're hopefully simplifying this one piece will decrease the back and forths. And then what Rob spoke about is templates, more like cheat sheets for right now. And then possibly those would be templates that we can maybe hone down and do what we're doing in the experiment with IBD, which is these are the most important questions that we want iConnect to ask for IBD. Yes, no, kind of a thing. Try that out, rework that, take these cheat sheets. Oh gosh, there is 5 things that keep coming up and up and up. iConnect can actually ask those before sending them to us. So that'll be a little bit more of a work in process. But the cheat sheets will come in great for new hires as well as orientation, as well as, Liz is covering liver today and, she's forgot about what to ask. So that piece. Janice actually tried this out, so a little bit on the phone, and also tried about, cross-covering while other people are the urgent. So if you want to just kind of briefly speak about that piece.
So what I did, I was covering Dr. Gare for Stephanie on yesterday, and so I actually got an opportunity to try out the new template. And essentially what I did was, and of course I copied, and the goal is that this is to help reduce messages in the pool. And so that means when Doug is with James Stevenson, if I'm in the in the office, I can be covering my messages, but I can be covering his urgents as well. And if I get an opportunity, maybe I can even cover some of his others. But essentially, what I did with Stephanie's patient, this is the patient that called in, this is Dr. Garay's patient. He called in and states that he needs to speak to Stephanie as soon as possible, and told the phone number. So I called him, and so I used the template. And so his primary concerns was he had a fluid buildup on his stomach and legs. He was having difficulty breathing, shortness of breath, hoping for a paracentesis. And so there again, I still have to dig through the chart and see that they have scheduled him for a paracentesis, but it's not till 11/9. And so my question, and so I put it up at the top for Dr. Garay to read immediately. It's like, this is what's going on with the patient, that the patient needs to be, my main question for him, does the patient need to be scheduled for a paracentesis sooner than 11/9? Of course I know that, but I'm just sort of throwing that out there to him. I need him to say yes, and then he can come back with me, and then I can move forward. And so I put all the steps, and then the next steps, and this was my misunderstanding. I thought that this was an opportunity for him to say, but actually that's the S-bar part, the recommendation from a nursing standpoint, where I would say, hey, do you want me to try to get this patient in tomorrow? Do you want him to wait for his appointment on Friday? And so that's what I sort of filled in there. And so then at the end, that's when I put all the details of where I'm explaining exactly what's going on to him. And it did make it a really easy, and it helped me that very rarely covers liver, but it gave me something to work with, and it gave me some things to push to Dr. Garay that he could address them more appropriately.
And when we say template, just to kind of, this is a dot phrase. So this is not something you're gonna write out every time. What
Correct.
we'll do is we'll go around and show you how to say that dot phrase, so that, you pull it up, you just hit that, it'll already be there. Primary concern will be highlighted. The next steps will be highlighted. Details will be bolded. So you're just gonna fill that in, and so it'll be real easy. The goal would be then, the providers who also get education about this, is that it'll be consistent for them. So if we get used to that format, still the individual stuff is still there, but it's in a format that's gonna be very easy to see and follow those chain of events. And hopefully it doesn't give people to be like, okay, I gotta move on to the next one because this is way too long. And so it's now gonna be incorporated into our standard work and revise. So it'll be new, it'll be, obviously it'll take some time to get used to, but
So what are your thoughts, comments, concerns?
So I kind of do that, not exactly in that way, but I put a 1, 2, 3, and I'm hoping to get an answer 1, 2, 3. Some of the doctors I work with just put 1 yes, 2 no, 3 maybe, or whatever. And then I have others that only answer one of them. So I guess that, and then I have to send it back to them. What about number 3 below, or whatever, so.
That's what we have to try then
I
to take to
find
the providers.
frustrating.
Yeah,
And then I'm sending it back and forth because they didn't answer all the questions.
Or you'll say, can we do this or this, and they'll say yes.
Okay.
Never you, never you.
So I think, right,
Nurse's
so
choice, what are we doing?
there's 2 parts, right? So the whole point of this, I think, is just trying to get, I think everyone's doing a great job. This is now trying to, polish and even further optimize. And then if there's still breakdown, then the finger pointing starts coming this way. Why are some people giving short answers? I don't know if there's an easy fix for that. There's certain things like making sure all documentation and notes and power plans from prior visits is up to date. These are things that I sit on the clinical cabinet for our group. We're meeting tonight, so these are going to be addressed, and from the physician side of things. But that's going to be a work in progress. But hopefully here, giving physicians the streamlined information, organized information, the hope is that leads to faster response time. Allows us to get that target that we're looking for in 48 hours.
it's also nice too that if, we've all been in a situation where actually Dr. Seawick went through this where you didn't have a nurse. We were waiting for Janice to start. So basically you had whoever was there that day, and so you may get one style of message from Tanya that day, but then got Liz's different style. By doing this, I think it'll be easier for them to kind of sort through their messages and actually answer all the things. The other piece